Clinical science demands strict isolation. To observe a pure chemical reaction, you place the subject in a sterile environment and subtract outside variables. Compare that to indigenous practices utilizing psychoactive plants. These traditions actively flood the senses with smoke, singing, and complex social interactions. Psychedelic-assisted therapy, or PAT, is entering mainstream clinical trials. But researchers are finding that standard double-blind randomized controlled trials are failing to capture accurate data. Classical psychopharmacology relies on standardizing the testing environment. To study a daily antidepressant, you neutralize the clinic room so only the drug's specific physiological effect remains. Hallucinogens break this testing model because the physical and social environment functions as the primary active variable shaping the drug's effect. Applying rigid, neutral RCT frameworks to psychedelics forces bad science. Capturing valid data demands a reimagined, pluralistic clinical architecture. This mandatory replacement framework for PAT trial design is called methodological pluralism. It operates on three distinct pillars: the mechanism, the mind, and the application. First, the mechanism. Researchers must accept that psychedelics amplify social context rather than producing fixed, predictable chemical outputs. Second, the mind. We require a strict biological classification for consciousness so that subjective patient reports are not dismissed as pathological. Third, the application. Clinical trials must adopt new ethical protocols to safely manage the metaphysical belief shifts caused by the compound. Mastering these three pillars is the only way to protect trial integrity and prevent the severe ethical errors of early psychedelic research. The effects of a psychedelic are dictated by set and setting. Set refers to the patient's personality and intention, while setting is the physical and cultural environment where the dose is administered. We can map exactly how this works through Bayesian inference, a cognitive science model describing how the brain constantly updates its predictions about reality based on prior knowledge and new evidence. Normally, your brain makes predictive bets based on cultural priors to interpret incoming sensory data. A psychedelic chemically disrupts and dampens that bottom-up sensory input. With sensory data fractured, cultural priors are left unchecked. They expand to overwrite sensory processing centers, dictating the phenomenological output. We see this clearly in the field. In an Amazonian shamanic center, participants undergo an education of attention. They are culturally primed to categorize physical nausea as a direct encounter with spirits. Apply that exact same mechanism to the pathological discourse of a clinical setting. A sterile hospital room acts as a negative cultural prior. Stripping away human comfort practically guarantees paranoia and corrupted data. Because a truly neutral psychological setting is biologically impossible, clinical researchers must actively design, document, and account for the environment of the trial. Even with a controlled setting, researchers face an epistemological hurdle. Once the hallucination occurs, how does a clinician measure a purely subjective, mystical experience objectively? The traditional trap is a categorical error known as dualism, the philosophical stance that treats the physical body and the conscious mind as two mutually exclusive substances. Operating under dualism forces clinicians to view subjective visions as a break from physical reality, leading them to dismiss subjective reports as temporary psychosis. To prevent this, data collection must operate under philosopher John Searle's concept of biological naturalism. Biological naturalism defines consciousness as a higher-level system feature of the brain.
It is directly analogous to how digestion is a system feature of the stomach. This specific classification allows the clinician to accept first-person subjectivity as irreducible biological facts rather than symptoms of a disorder. Adopting biological naturalism bridges the subjective-objective divide. It allows researchers to document profound mystical experiences without pathologizing the patient's reality. The historical consequence of failing to synthesize third-person rigor with first-person experience is perfectly illustrated by the 1962 Good Friday experiment. Researcher Walter Pahnke administered psilocybin to theology students. His explicit goal was to empirically measure and categorize mystical states of consciousness. This table details Pohnkie's methodology. He relied on Walter T. Stace established philosophical criteria to classify these mystical states, comparing Pohnkie's 9 observational categories against Stace's 7. Pohnke systematically matched participant reports against complex criteria like a sense of sacredness, unity, and alleged ineffability. The data appeared clean, but it concealed a fatal methodological flaw. During the deep stages of the experiment, a subject panicked and lost control. To manage the participants' behavior, the researchers intervened and administered a powerful tranquilizer. Pohnke omitted this secondary pharmacological intervention from his official reports and datasets. The objective medical gaze overrode the subject's total biological reality. The clinicians buried the physical facts in order to preserve the scientific classification of their study. True methodological pluralism requires absolute transparency. Validating non-reductive first-person reports is impossible with rigorous third-person pharmacological logging. The final bioethical hurdle in TAP clinical design is managing the psychological aftermath and ontological stability of the subject post-trial. Psychedelic states regularly produce a phenomenon known as the noetic quality. This is a state where the subject feels they have gained direct, authoritative insight into absolute truth. This noetic quality frequently triggers massive metaphysical belief shifts. Patients often enter a trial holding naturalist views and leave endorsing non-naturalistic frameworks like panpsychism or theism. If the trial lacks a dedicated integration framework, returning to normal reality with an upended worldview poses a severe psychological risk to the patient. Preemptively identifying and ethically managing these belief shifts serves as a strict clinical requirement for participant safety. To manage this, modern PAT trial designs must implement a definitive 4-step risk mitigation protocol. Step 1. Baseline metaphysical assessment. Researchers must document pre-existing worldviews to track belief shifts as objective clinical variables. Step 2. Total pharmacological logging. Researchers must record the primary agent and absolutely all secondary interventions to prevent historical omissions. Step 3. Set and setting controls. Researchers must actively document the environmental variables and cultural discourses framing the dosing session. Step 4. A strict non-proselytization mandate. The World Psychiatric Association strictly forbids clinicians from using their position to push spiritual or secular worldviews. Clinicians must maintain pluralistic secularism and allow the patient to independently process their own conclusions, rather than providing a menu of metaphysical options. By acknowledging the reality of subjective experience within a rigorous biological framework, we advance the study of entheogenic states out from the fringes and into a legitimized medical science.